this session is on exercise tests, and the three speakers for this session are Dr. Don Rasmussen, Dr. Attorney Leonard Staten, and I don't see him, but I think he's coming from a talk on blood gases, which I think has run over, and myself. We're really going to give you a bird's eye view of exercise testing. It's a very complex test, and we certainly don't wish to cover all aspects of this test. So my job is to provide an introduction and then discuss some of the limitations or words of caution that's related with the use of exercise testing. And I do want to start with a disclosure slide, just like Bob did. He had lots of disclosures to make. I only have one disclosure to make. I'm really weak in physiology. So if you have any physiology questions, the person to ask is Dr. Don Rasmussen, who's really the expert in this area. And I think lots of audience would appreciate that too, because I'm sure lots of audience are also weak in physiology. So there are three reasons to do an exercise test. The first reason, and actually the most important reason, is to demonstrate disabling gas exchange abnormalities during exercise when none are present at rest. And this is what the Black Lung Benefits Act really wants, is an exercise blood gas. And that's usually the commonest and the most important reason to exercise patients. Now, when you're doing, when you're trying to meet only this indication, you do not need what is called a cardiopulmonary exercise test. And you can really get by with a cardiac stress test with an arterial line. But if you really want to meet the other two indications, you need to have measurement of oxygen consumption. If you want to measure oxygen consumption, you will need to have a cardiopulmonary exercise test. So using a cardiopulmonary exercise test, you have two other reasons to exercise a minor. To calculate the maximal oxygen consumption, and that's measured in milliliters per kilogram per minute, or it can be translated into METs of activity. MET stands for metabolic equivalence? Metabolic equivalence. And then it can also be used to determine what's called anaerobic threshold. Anaerobic threshold is the threshold where your exercise physiology switches from aerobic to anaerobic metabolism. It's also the threshold which defines how much time you can, or at what level can you do prolonged physical activity. Now, how anaerobic threshold is measured is beyond the scope of this talk today, but I'm just going to mention anaerobic threshold, and this is the only time I'm going to actually mention it. The third reason to exercise someone is to determine that exercise limitations from lung reasons and not from other reasons such as cardiac reasons or pulmonary vascular reasons or obesity or deconditioning. So those are the three reasons to exercise somebody. And again, I'd like to mention that the most important reason to do an exercise test is to determine disabling gas exchange abnormalities during exercise. So I want to warn you that when you receive a report from an exercise test that's conducted in a laboratory, you should expect a report that is ununderstandable. It has really a complex alphabet soup. And if you think pulmonary function tests are complicated enough, exercise tests takes being complicated to a whole new level. So what you get in this report is a whole bunch of acronyms. Those acronyms can be very confusing and sometimes make absolutely no sense. But the most important numbers that you're looking for is VO2 in ml per kilogram per minute. You're looking for METs. And then if you go on to the next part of the report, you're looking for PaO2. Here's the small a that matters, which is the arterial oxygen. You use that, compare it to the partial pressure of arterial carbon dioxide, and you use the tables to determine total disability. So remember, you want to look at the rest values, you want to look at the blood gas values at anaerobic threshold and blood gas values at peak activity. But usually the most helpful blood gas is the blood gas at peak activity. So once this report is read, people, the physicians actually reading this report can give a determination of whether this individual stopped exercising due to cardiac disease or due to lung disease. And if it is due to lung disease, it's actually helpful for you. Okay. So, like the ATS has its standards for spirometry that all attorneys refer to and all physicians refer to, the ATS ACCP also put together a standard for exercise testing. The standard was written in 2003. It is 66 pages long. And after that, nobody has dared write another standard because there's so much data in those 66 pages. And following this, the publication of the ATS standards, came actually an editorial, and I love the editorial. It says, data from cardiopulmonary exercise testing are, and I'm not kidding you here, most difficult to interpret. And the good news is they're very difficult to interpret for the company doctors, which basically means that the company doctors don't really question you a lot on cardiopulmonary exercise testing, even while they nitpick on every little aspect of spirometry. The editorial goes on to say, although the ATS ACCP stands for American College of Chest Physicians, statement is comprehensive, it must be approached with zeal in order not to be overwhelmed. And then it says, it will not allow us to just hand it to the fellows, and if I'd like to cross that out and say attorneys, and have any hope that it will be read. So just to give you some idea that this is really complex data. But in the hands of experts like Don Rasmussen, this is incredibly useful. I also wanted to point out some contraindications. The contraindications are conditions where you should not do this test. And there's a very long list of contraindications. They're divided into absolute contraindications and then relative contraindications. And I really have no intentions of going over this entire list. But I really wanted to point out two contraindications because these contraindications are often misused by company doctors to argue that an exercise test should indeed not be performed. The first contraindication is unstable angina. Now, unstable angina basically means someone who's having recurrent chest pains of increasing frequency or occurring at rest. Now, that does not mean that someone who had prior coronary artery disease and has had a coronary artery bypass graft or a stent placement should not undergo such a test. Those people can safely undergo these tests. These tests are unsafe in people who have unstable coronary artery disease. The second contraindication is a relative contraindication, and that is orthopedic impairment that impairs or compromises exercise performance. Now, the whole idea is not to exercise someone who's going to fall and hurt himself or herself during the test. And in general, exercise bicycles are safer than exercise treadmills in terms of fall risk. But it's a relative contraindication, and everyone who's got arthritis doesn't necessarily mean that it's a contraindication to have this test. But the two major reasons why company doctors state that this test should not be done is unstable angina and orthopedic impairments. I also wanted to point out that although it's a very, very safe test, particularly done in competent hands, this does carry a small, finite risk. There's a risk of dying during this procedure. The risk of death is 2 to 5 deaths per 100,000 tests. And there's a risk of causing a major myocardial event, such as a heart attack, and that occurs in about 12 per 100,000 cases. So what that really means that if a clinic is actually doing these tests, they need to have the proper resuscitative equipment and competent people on hand should such an event occur. Now, having done quite a few tests myself, and I'm sure many more have been done by Dr. Rasmussen, these kind of risks don't occur. In fact, our biggest problem is vasovagal syncope, which is simply a very benign condition which people feel dizzy at the end of the test. And even that doesn't occur very frequently. Do you want to say something on the risks of these tests before I carry on?
No, only to say that I pay close attention to the risks, and we're very careful. And we've had a very, very good record of having no major untoward events. But we're very careful about the contraindication.
Okay. So if you're going to do a full cardiopulmonary exercise test for all the three indications we talked about, it's very important that the exercise test be performed maximally. Performing maximally is of tremendous importance because as in a submaximal test, the hypoxia may not be visible, and therefore a maximal test may unmask gas exchange abnormalities better than a submaximal test. It also allows you to determine VO2 max values. VO2 max values are the maximal oxygen consumption values that allow you to determine how much a person can exercise and what percentage impairment can be given to the exercise capacity. And most importantly, if it's a maximal test, you can figure out that there is limitation from lung disease. Otherwise, you'll basically state that this is poor effort or neuromuscular disease as the cause of the test not being completed. Now, there are certain ways, as I said, it's really essential for the second and the third indication. It's ideal for the first indication. If people have advanced disease, they can develop gas exchange abnormalities even early on, and then it will be very obvious. But for people who have relatively early disease, it's very important to have a maximal test. There are certain criteria that allow us to determine whether a test is maximal or not. The first and the most important criteria is whether maximal heart rate has been reached. So there are certain predicted heart rates that we expect people to reach at peak activity. And if they are reached, then we can be quite certain that this indeed is a maximal test. But then there are many people whose heart rates don't change. Either they have heart disease or they are on medicines such as beta blockers and calcium channel blockers. And then we have alternative ways of determining whether a maximal test criteria was reached or not, and some of those criteria are written here. But what really happens in the real world? What happens in the real world is submaximal tests get performed. These include what's called an ambulation oximetry followed by an arterial blood gas. They're also called 6-minute walk tests with or without a blood gas. These tests are not maximal. They're submaximal, and they are often used by company doctors. There are also, in the real world, lots of maximal tests that get used, which are really cardiac and not cardiopulmonary stress tests, without oxygen consumption measures. And I really don't have a problem with that, except that the second and third indication I talked about cannot be assessed, but the first indication can be adequately assessed. Now, I can tell you that in New Mexico, which is a pretty large state, there's only one institution that can do a maximal cardiopulmonary exercise test, and 12 institutions that can actually do a cardiac stress test with an arterial line. So in terms of availability and accessibility, this is a reasonable test as long as it is associated with an arterial line. So I can tell you that at Miners Colfax Medical Center at Raton, we do a Bruce protocol treadmill with an arterial line, and we do not do VO2 measures. But when we do the same test at the University of New Mexico, we do it on a cyclogometer, and we actually do oxygen consumption assessment. But then there are lots of people who actually measure METs, and then they try to use those METs in rating impairments. And I need to warn you that METs that are measured outside a cardiopulmonary exercise test tend to be inaccurate. So I can tell you that my treadmill at home gives me a METs assessment based upon exercise grade and speed on the treadmill. And it is not accurate enough for us to use in rating impairment. And some people also estimate METs based upon duration of exercise and heart rate or heart rate variability, which is also not accurate enough. What other things happen in the real world? Exercise tests get done which are of poor quality. And the patient does not put in a good enough effort. These tests are submaximal. They do not meet the ATS criteria. Thankfully, they don't reach the same level of scrutiny because people don't know how to scrutinize these tests. The company doctors are very good at looking at PFT quality, but they really can't determine the quality of exercise tests quite as well. The equipment doesn't get well calibrated, and personnel may not be adequately trained. Further, this equipment is very expensive. I think there is a message that's going to go out again and again about the use of arterial lines during any exercise tests. Arterial lines are often not placed. In fact, I'd like to have a show of hands of all medical people who put arterial lines routinely during exercise testing. So we have 6 hands actually, although you folks are all in Don Rasmussen's team, so you really don't count. But arterial lines... arterial lines often do not get placed. When they do get placed, arterial lines can get clotted or displaced during this exercise test, and often the blood gas gets performed through a stick after the test is completed. Some people consider arterial line placements as invasive, and many pulmonary function test laboratories will not do cardiopulmonary exercise tests routinely with arterial lines. And there is now data which says that if you use ultrasounds to place your arterial lines, you have fewer sticks, and you can do it quicker, although it probably doesn't apply to Dr. Rasmussen's laboratory, where I saw the amount of time that they take for placing arterial lines, which is really shorter than the time we take to put ultrasound-guided arterial lines. But again, there is a need to start using ultrasound to put arterial lines. So let me ask a show of hands. Who uses ultrasound to put arterial lines? Nobody. Okay. I'm so sorry. I'm going to skip this slide because I think I'm going over my time. But I really do want to tell you about the American Medical Association's Guide, 6th edition, and how it uses VO2 max to rate impairment. As you can see, as the VO2 max value decreases, the impairment class increases. And if the VO2 max value is greater than 25 ml per kilogram per minute, that's really an impairment class of 0. If you have an impairment class of 1, the VO2 max is about 22 to 25 ml per kilogram per minute, which corresponds to a MET value of about 6.1 to 7.1. Now, within the chapter in AMA Guides that relates to the respiratory system, there is another table. This table is actually taken from Astran and Rodal, and it allows us to look at estimated anaerobic thresholds, which are estimated at 40% of the maximal oxygen consumption, and they can be plotted against these charts so we can understand what prolonged physical work intensity an individual can do. And those are very useful in people who have borderline impairments of class 1 or so to determine that they may not be able to work in intense positions. But I do want to tell you that the energy requirement of coal miners has not been very well studied. And as a result, we really don't know what is the energy requirement of a miner operator, for instance. There's a small study that was done by Harbour all the way back in 1984. He looked at 12 underground miners. He first established a linear relationship between heart rate and oxygen consumption, and then he let the miners work in the mines, and he monitored their heart rates during various activities, and then extrapolated VO2 maxes from the heart rate. And as you can see, most miners, work with heart rates in this level, suggesting that they don't work at very high intensities. But for a minority of time, you can see that they require very high, their heart rates climb up to very high levels, suggesting that they need to do very vigorous activity. And this is what he basically found, that the mean of subjects' median exertion was only 3.3 METs. But the average 90th percentile was 6.3 METs, and Dr. Rasmussen would agree that what really matters is whether the miner can do the most intense activity in their job, even if that activity lasts for only 10 or 15 minutes in a whole day. So you can use the second table that I have on the right-hand side to actually make an argument that this individual cannot perform prolonged physical intensity. I do want to point out about geographical accessibility. So there are 15 black lung clinics. To the best of my knowledge, only 2 of those black lung clinics that are located in very large cities, Chicago and Denver, who can actually perform cardiopulmonary exercise testing. I know West Virginia, you folks do it, but you are an independent entity, as I understand. We can do cardiopulmonary exercise tests at Albuquerque, but at Miners Colfax Medical Center, where our coal miners program runs out of, we currently have the capability of doing a cardiac stress test with arterial line, although we do intend to upgrade ourselves to be able to perform a maximum cardiopulmonary exercise testing there as well. There's another thing that I wanted to share with you, and that is these exercise tests are very expensive. So at University of New Mexico, this is what Medicare, the government, reimburses us for an exercise test. And you can see that the facility fee adds up to about $1,900, and the professional fee adds up to $450. Now, why this is important is because the reimbursements from the Department of Labor are generally to the tune of about $400. For that $400, we can't even cover the cost of an arterial line, because an arterial catheter itself costs about $900, which is the reimbursement from Medicare. So there is, in fact, a tremendous financial disincentive to DOL examining physicians to actually put an arterial line. And then to do 5 blood gases, which is what we routinely do now, it really drives up the cost. So the amount of reimbursement that we get is far less than the amount of expense that this test requires. And we have a very generous CEO who actually pays for this test and is very committed to performing these tests. But there is a tremendous financial disincentive to a general physician towards performing this test. So I'd like to conclude by saying the following things. A cardiopulmonary exercise test is very useful in the right hands. But it is complex, which you can use to your advantage because many company doctors don't understand that. It carries a small but significant risk. It is contraindicated in a significant proportion, although we have to be careful that the contraindications are used correctly. It's often inadequately performed. The work requirements of coal mining jobs in METs are not precisely known. I didn't discuss this, but weight adjustments in VO2 ml per kilogram per minute puts in the weight of the individual, and if you're obese, it tends to lower your VO2 max values because it's adjusted for weight. And weight adjustment favors obese individuals during impairment evaluation. It's difficult to access geographically since many mining communities are not located near large towns, and it's expensive and inadequately reimbursed. Particularly, there is no incentive to a physician to place an arterial line. With that, I'd like to take questions. And I'll be happy to at least attempt to answer them. If I can't answer them, Don will. Sorry. You know, this is a difficult area to talk about, so I would really appreciate a question. Yes.
In an exercise test, if an indwelling line is not applied, is there any minimum amount of time that can pass and still produce a valid ABG test?
Okay, so the question that's being asked is, if you do not put an arterial line, what is the minimum valid time, minimum time so you can still have a valid arterial blood gas? There's going to be an entire talk on that question, and Dr. Don Rasmussen is going to try to answer that. So I'm not going to answer that question quite as yet. Yes, sir.
Just if you have two exercise blood gas studies, and let's say one, the heart rate gets up to 120, and the other one maybe it only gets up to 80, would you be able to say that one where the heart rate is 120, that would be a more valid blood gas study of the same person?
Okay, so the question is, if in the same person the heart rate goes up to 80 in one test and the blood gas is drawn, and goes up to 120 in another exercise test and the blood gas is drawn, can we say one is more valid than the other? Attorney Staten has exactly that case that he's going to discuss. So I'm clear off the hook. I don't have to answer the second question. But I would appreciate a third question, if any. Okay, 2 more questions. That makes me feel happy.
Dr. Zaldivar's reports, for instance, and his testimony that I stuck him at maximum exercise, and that's valid, and I can tell he can do his work because of that. But there's no time, he doesn't put him through an adequate time frame. So he really can't make that statement, can he?
So just imagine, I'm walking like this, and someone's trying to stick me in my artery. I mean, how long would it take? It would take forever. So what do you have to do? You have to tell him, can you please sit down and give me your hand? So I sit down, I give my hand to him. Obviously, it's post-test. And that person's digging around my artery. It can take anywhere from 30 minutes to 3 minutes, 30 seconds to 3 minutes to get the blood gas. Now, Attorney Staten has an example and some piece of advice as to how to do this. And I'm going to let Attorney Staten handle that again. But it is true that you cannot get a single stick blood gas at maximal exercise. It just is not going to be possible. Okay, I saw one more hand. Any other question? Yes, sir.
Is there, if the resting test shows normal values, does that carry any significance with regards to the ability to do work activity?
So, and I think Dr. Rasmussen is going to show this data too. But in general, I can tell you the resting gases have very little usefulness. From our own experience, ever since we started doing arterial blood gases through arterial lines, our eligibility has tripled. So I think if you rely only on resting blood gases, you're going to miss 1 in 4 individuals, 3 in 4 individuals. You'll only be able to use 1 out of those 4 qualifying individuals that help them along. So I think its utility is very limited, and it really needs to be complemented with an exercise gas. Would you like to say anything to that?
No, I'll make a comment.
Okay, good. But I do have a question for Dr. Rasmussen, and if you want to answer that afterwards, that's okay too. The DOL says that if you already have a qualifying blood gas at rest, you don't need to exercise these individuals. Right? Does anyone here exercise these individuals anyway to generate additional data? You do. So can I get your rationale for that?
Well, because the resting sample may be very abnormal at rest and rise to normal during exercise, and there are so many non-lung causes of resting hypoxia that it really it's almost useless, as you say.
So,
value of that.
Dr. Rasmussen, does that mean that if people meet a qualifying blood gas at rest and do not meet qualifying blood gas with activity, you would not support such an individual's claim for total disability?
I may say, based on that blood gas, he may be total disability, but I'm never able to say that it's due to his lung because I don't know. The exception would be the individual who has hypercarbia and hypoxia. He's going to have obstructive lung disease, and you could explain it that way, but you can't take an individual, for example, with a normal ventilatory function, a normal single perfusion capacity, with a qualifying blood gas. I could never say that that's due to lung disease. Obesity is the number one factor, but other factors occur as well. It would be fun to talk about all the very other fascinating aspects of exercise study, but I'm going to do 2 things today. First, I'm going to demonstrate the value of doing proper cardiopulmonary exercise testing and also show the absolute folly of attempting to get an accurate post-exercise sample. We study, since at the June conference, I was disturbed by how many people did not use an indwelling catheter, which means they therefore did not get valid exercise blood gas studies. Even though many of them are well-trained, they seem to be unaware of the medical standards. What I'm going to show you is not original. It was published 35 years ago, and I was taught that in 1959 that the blood gas rose promptly after exercise. But what we did was after the conference, we studied 100 of our patients that we exercised. We drew samples of blood at rest and at baseline, which is different than resting. It's standing on the treadmill. I'm not going to show you the resting values because they are irrelevant. But at any rate, we drew samples of blood in our routine fashion. We draw our blood at maximum. We draw a blood sample every 2 minutes, and during the last 30 seconds of the highest exercise the patient can achieve, we try to get a maximal study on every patient. The two big factors that prevent us from doing so are deconditioning and orthopedic problems in coal miners. And I agree with Dr. Sood that a bicycle ergometer could probably allow us to safely exercise other patients. But nonetheless, these patients were exercised to their maximum capacity. The minimum, at least 4.5 minutes. We prefer to exercise the patients as far as they can go, 10 to 15 minutes with progressive exercise. But that was basically the minimum. This is a summary of the mean values of PCO2 and PO2 at baseline on the left, then at the peak exercise, then at 30 seconds post-exercise, and then at our usual 2-minute post-exercise study. We routinely draw that 2-minute post-exercise to see if we can detect evidence of maximal test by way of how much the bicarbonate dropped. We don't look at the option because it's invariably going to be absolutely normal at 2 minutes. But what we found was that initially there was a slight drop in PO2 between baseline and exercise on average. But look at the rise in PO2 on average 30 seconds after the exercise stopped, and then the further increase at 2 minutes. Now, of these 103, there were 12 miners who met the Department of Labor listings. It's a little higher than our general average over the years, but that's about what we saw. Now, that means they had PO2 values of 60 with a PCO2 of 40 and so on down the line. So the mean value at baseline was 72 millimeters mercury. The mean value at exercise was 57. But look at what happened at 30 seconds. The PO2 rose 9 millimeters mercury on average. And by the 2 minutes, they were absolutely normal in every case. Now, we looked at these cases. We found that of those who met the criteria at peak exercise, 5 actually met the criteria at 30 seconds. They all had PO2s between 50 and 55 millimeters mercury during peak exercise. And the PO2s rose 4 to 8 millimeters mercury at least during that time. So those 4, by chance, you might have found a qualifying number, but in all of the others, they would have shown no qualification at 30 seconds. And now, we also looked at how long it took our respiratory therapists, and they're pretty hot shot at doing the single stick on patients we didn't exercise. We never do a single stick if we're not going to exercise the patient, but those patients that we did not exercise, they just took an average of how long the time it took them to draw that's the test. You can see took an average of 38 seconds. That's with the patient standing quietly on the treadmill after the exercise. Now, you couldn't have gotten this man off the treadmill and have him sit down and even try it at 30 seconds because there's a time limit. Some of the studies from the literature that we'll talk about are only say you can't really get it in less than 40 seconds. So you would have missed a good many of those studies, just if you were able to start the stick immediately after the exercise. Now, we got some pretty good people. This is the average time that it took them to put an arterial catheter in. Misty Barnett is our best one. She's been with us 4 years. Jim Cornett has only been with us for less than a year. She's hot shot. He's a close second. I used to be the best at everything. But some of those outliers would be my time. So, but anyway, so that's in experienced hands. So that's it. It absolutely demonstrates that it is impossible to get an accurate post-exercise blood gas sample. There just isn't enough time. The change is too rapid. Some of the changes show, some of the studies show a change in 10 seconds, 5 millimeters in 10 seconds. So that's the case. Now, I've listed some references. I must apologize because I just noticed that Rice is spelled R-E-I-S instead of I-R-I-E-S. But anyway, they show values that are just like our own, and they've been published that long ago. I've been preaching this for all those years. It wasn't because of it's what I knew would happen, but anyway, that shows you something. Randy Forham published at least a poster study looking primarily at arterial saturations, but he also included blood gases. It showed the same phenomena, and we routinely monitor saturation. I can show you some beautiful graphs of how rapidly the saturation rises after exercise. At any rate, we decided to demonstrate our technique for putting in an arterial catheter. So we had Misty do the catheter. Jim was the videographer and the go-to guy to get your things fixed. But at any rate, we'll show you our technique now. There are the New England Journal, for example, has a website. I think we've included that in of our references. And we've got copies of a few copies of those references that we'll show you when we show you we have available for you. Ready. This is a tray that we have got our catheter, we've got a sterile needle, we've got carbocaine and saline. We'll show you those things here now. I don't know if the sound is on or not, but Misty is going to she's putting a tourniquet on. We use a tourniquet to get hemostasis after she gets the catheter in. Right now she is doing an Allen's test to make sure we have adequate collateral circulation in the hand. We never puncture both the radial and ulnar on the same arm. Primarily you use the radial because it's easier. You can use the ulnar, but it's harder to hit. She's doing a fairly wide, generous alcohol wash just to discourage some of the microorganisms. She'll now inject a local anesthetic. We usually inject the material about along each side of the artery, up about 2 to 3 inches. We do that to give more stability to the artery, more anesthesia, and we think it tends to prevent spasm. And also, you may have to make another puncture a little later, a little further up. So she does that. Now the most uncomfortable part of the test is that simple little needle to put your local anesthetic in. I used to use a lot more than she's using, but she taught us that you don't need that much. At any rate, that will give very, very good anesthesia, and we almost never cause discomfort when we're putting a catheter in. She's now making an entry way or an entry hole through the skin because the catheter, she's using an 18-gauge needle. The catheter is smaller and the catheter itself sits on the outside of the needle and it's more fragile. And if you try to push it through the skin, it will sometimes cause a flange on the end of the catheter. It makes it harder to get into the artery. Now, she'll insert the needle in, and she'll see a quick flash of blood right between her fingers. She'll then advance the stylus, which is basically a dull wire inside the needle. And then she's going to slide the needle or the catheter off across along the stylus. She showed us where she could tell she's getting a blood flow by looking in there. You don't have to lift the stylus out. We'll leave the stylus in till she gets this thing wrapped up. She's putting a sterile dressing there. We're now going to put a pressure dressing. We think that over the years that a lot of the mortality or morbidity, it says, morbidity that comes from catheterization is blood extruding outside of the artery into the tissues. So we try to eliminate as much of that as we can. She's now going to attach a little tube in order to allow us to connect the catheter with the three-way stopcock on the sterile saline syringe, which we also get commercially, and she'll flush the catheter to keep to remove the blood from the catheter so that it won't coagulate in the catheter. Now she's making sure she has it tucked in very well because we don't like to have a catheter come out, and we've developed a means of we use enough tape in the right places to prevent it for the most part. We'll occasionally have somebody that can manage to do it, but we usually don't. Now she is sampling the blood. Now what she's doing first, she'll take a 3 cc syringe. We didn't show it there. She'll take a 3 cc syringe, flush that out, and throw that away because she's trying to remove the saline from the catheter because we don't need to do a blood gas value on sampling on saline. So she clears the saline out, then draws the sample blood. We use a commercially available 3 cc sampling syringe that's pre-heparinized, so we know exactly how much heparin's in it. If you make your own syringes, you have to be very careful to remove the excess heparin because the heparin can have a high PO2, so you get a false value. But that's basically our technique. As I mentioned, the New England Journal has a website, but it's a much more complicated procedure than we use. And that's basically the message. Blood gas exercise studies are valuable. They need to be done right. You can't collect the blood afterwards and get any kind of an accurate response. Thank you.
Just one question for yeah. Go ahead.
Just Don, I think that's phenomenal work, and I think that if you can write that up, I think it would certainly be. Even though similar work has been done before, I think we continually need to pound this, and I think that your data is excellent, and would certainly any examiner that attempted to say that a single stick was adequate would be, I think that would be completely refuted by this excellent work that you've done. And maybe we can also use your videos for some of this training that we're trying to do, because it's phenomenal work. So we'll talk about that, as they say in Brooklyn. We'll talk, but I think that's great work, Don.
They got another one when we did the video too. The problem is that many physicians don't understand this. More lawyers don't understand this, and unfortunately, no law judge understands it.
Well, thank you, Dr. Rasmussen. You've done this every year. You've hammered this point, so thank you. Yeah. So last but not least,
you've done 40,000.
It was 40,000 10 years ago.
Still counting.
Okay.
Last but not least, we have attorney Leonard Staten, and he's going to try to get the microphone off Don Rasmussen, and I think he's managed it. So, Attorney Staten,
okay.
There you go.
Can everyone hear me all right? Okay. Well, I've given you a handout. I'm going to talk today about some of the common errors I see from a legal standpoint in the administration and interpretation of arterial blood gas studies. And what I'm going to say is going to second what Dr. Rasmussen says. The number one problem I see in exercise arterial blood gas studies is that the blood is not drawn timely. If you look at the regulation, it says that the blood shall be drawn during exercise. And the reason for that is that Dr. Rasmussen has demonstrated the PO2 rises rapidly after the exercise ends, so if you wait too long, you don't have a valid estimate of the functional capacity of the patient. So we've seen today the indwelling catheter is the best method. The ATS says you can take it by a stick, but that's difficult because, as Dr. Sood showed, when somebody's at peak exercise and swinging their arms, it's difficult to draw the blood. And if you wait till after peak exercise ends, you wait too long to get a valid result. But merely because you use an indwelling catheter does not mean you get an accurate result. In my area, the company doctor that probably performs the best test from the mechanics of it is Dr. Zaldivar, because he does use an indwelling catheter. But what my clients tell me is that even though he uses the indwelling catheter, lots of times he won't take the blood until after the exercise ends. So if he's waiting too long and after the exercise ends, then he's not getting a valid result. Of course, now he does it differently than Dr. Rasmussen does. If you notice on Dr. Rasmussen's testing, if you ever had one of your clients go to him, he makes multiple draws of the blood at rest, baseline, and during the exercise. Dr. Zaldivar only takes one blood draw, which my understanding of the reason why he does that is because he doesn't do it in his own lab. He sends them over to the hospital, and the hospital charges him per draw, so he only does one draw. And in my paper that I've given you, I've got data from different examinations attached to pages 1 through 12 of the attachments, and we've got a case of Mr. D who went to Dr. Rasmussen, who did a study with an indwelling catheter, and at peak exercise he had a PO2 of 61. He then went to Dr. Jarboe, who did an exercise study, but then drew the blood by stick, but the PO2 was 84.6, so Dr. Jarboe said, well, it's 84.6, so there's no pulmonary impairment. But the flaw in Dr. Jarboe's test was that Mr. D's daughter had accompanied him to Dr. Rasmussen's examination, and Dr. Rasmussen explained to him about how the study should be performed, and the daughter went home and researched it on the internet and figured out how to do it. And she's a runner, so she took her stopwatch with her when she went to see Dr. Jarboe. And so Dr. Jarboe's test, as timed by her, the interval between the end of the exercise and when the blood was drawn was 3 minutes and 34 seconds. And so, Dr. Rasmussen shown by 30 seconds, 60% of the ones that qualified would not have had a qualifying study. So obviously 3 minutes and 34 seconds was too long, so that wasn't a valid result. So, that's something I think that we need to address. I know I've talked to, some of the lawyers and some of the doctors, and apparently, as Dr. Sood has said, it looks like the biggest prohibition against doing an indwelling catheter is the cost. Now, I called Pikeville Medical Center, which is a facility in our area where a lot of the company doctors do exams, and asked them if they could do an indwelling catheter. They said they used to do them, but that they had to have an anesthesiologist present, which, talking with Dr. Rasmussen, apparently that's not really necessary because he doesn't use an anesthesiologist, but apparently, it's a cost-prohibitive thing with them. Now, I want to talk a minute about resting studies. Someone asked about, can you rely upon a resting study? What Dr. Rasmussen has taught me is that resting studies are useless. First of all, because they're variable. If you look at Mr. D's case on small I in the attachments, when Dr. Rasmussen did a resting study, he had a PO2 of 53, but then on page 5 of the attachment, when he saw Dr. DeHaan, he had a PO2 of 67.9 during the resting study, so you had over a 14 millimeter difference in mercury between the two tests. So resting study can be variable, and the biggest thing I see come up in my clients that affect the resting study is obesity. When you have an obese individual, if he's in a seated position, often he'll have a large abdomen, and it'll compress his lower lung units, so you don't get an accurate measure of his blood gas. In Mr. D's case, when you look at the example from there, when Dr. Rasmussen does his study, he does a seated resting study, but he also does what he calls a baseline study, and that's when he has the person just stand on the treadmill and he takes the blood at that time. Now, if you look at Mr. D, his PO2 sitting was 53, but when he just stood up on the treadmill, his PO2 went up to 64. So just from going from a seated to a standing position, his mercury rose 11 millimeters. So the resting, in my opinion, is not a valid measure. And I see the obesity misused a lot by company doctors in interpreting the testing. So if you take the fact that obesity may alter the resting study and abnormally reduce it even if there's no lung disease present, then oftentimes I'll have a doctor, like I had a case in Mr. D's case. He went to Dr. Jarbo. In Dr. Rasmussen's study, his resting was 53, but his exercise was 61. Now, if you have an obese individual with no lung disease, normally with exercise, his PO2 will rise because he has increased ventilation. So what Dr. Jarbo said was, well, the PO2 went up with exercise, therefore he has no oxygen transfer impairment. But his error was he did not look at the baseline study. The baseline study performed by Dr. Rasmussen was actually a better depiction of whether he had an oxygen transfer impairment at rest. And his baseline study was a PO2 of 64, and then when you compare that to the exercise PO2 of 61, his PO2 did decrease, therefore indicating that he did have an oxygen transfer impairment. I'm trying to be quick here. I try not to talk too fast, and I don't have a whole lot of time here. And then the question of whether the exercise was done hard enough. Lots of times I'll get a report in from the DOL examiner, and he'll have done a proper arterial blood gas study test, and it'll show disability. The company will send him out to one of their doctors. He does an exercise test, and it comes back, and the doctor says, there's no pulmonary impairment. Everything's normal. So, I'm looking at the case and thinking, well, what have I done here? Have I taken a losing case, which if you just look at the test on their face and compare them, I've messed up and I've taken a case and I'm going to lose. But you can't just look at the values on their face. You have to look at the factors that were involved in the test. And some of the factors that you should look at are the length of the test, whether the miner reached his anaerobic threshold, the oxygen consumption achieved, his heart rate, and whether the bicarbonate dropped. So if you look at page 6 of my handout, we had a gentleman who went to Dr. Rasmussen for a test, And then he went to Dr. Zaldivar. Dr. Rasmussen found that he had an oxygen transfer impairment in light of the fact that his study met the listings. Dr. Zaldivar exercised him, said he had no pulmonary impairment whatsoever. But when you compare the factors, Dr. Rasmussen exercised him for 6 minutes and 53 seconds, but Dr. Zaldivar only exercised him for 2 minutes and 59 seconds. So Dr. Rasmussen exercised him over twice as long. In Dr. Rasmussen's study, he reached his anaerobic threshold, but in Dr. Zaldivar's, he did not. And of course, your anaerobic threshold is an indication of whether you're putting out effort, whether there's lactic acid being produced that's going into your muscles. The oxygen consumption in Dr. Rasmussen's test was 19.1 compared to Dr. Zaldivar's of 11. So Dr. Rasmussen's was 74% higher. Dr. Rasmussen's heart rate was 115. Dr. Zaldivar's was 93, which was 24%. Dr. Rasmussen's 24% higher. And then Dr. Rasmussen's study, the bicarbonate dropped 0.8 milliequivalents, while in Dr. Zaldivar's it rose 1 milliequivalent. And your bicarbonate, if it drops, then that's an indication of whether effort was expended. So in this case, the administrative law judge compared the two tests and agreed that Dr. Zaldivar's test was not sufficiently performed to give an opinion as to whether there was a totally disabling pulmonary impairment. So if you have studies like that, you need to look at the individual factors and compare them and see if they were done properly. And then as Dr. Sood has said, there are contradictions to exercise testing, but what we have to remember in exercise testing is exercise is something that we do every day. Even the most disabled client, they still exercise. Most of them, they'll walk to the mailbox, that's exercise. They walk from their chair to the refrigerator, that's exercise. So everybody exercises, and when you're in the lab, you're actually in a safer environment than you are at home. You have professionals who are there to monitor you. You have resuscitation equipment, and you have people that can monitor your condition and make sure that you're not in trouble and stop it if it gets out of hand. So lots of times what I'll have, especially in a case where I'll have the man has normal ventilatory studies, and then you have an exam that a gas exchange impairment is demonstrated, I'll have a later study by the RO doctor, and he'll find some reason not to do the exercise study, and then he'll say, well, because of the normal vents, this man has no pulmonary impairment. And of course, what you need to do in that case is go back to either your examining doctor or your RO doctor and have him explain why, since you don't have the exercise study, that RO's doctor is insufficient to determine in this case whether the man does have a totally disabling pulmonary impairment. And I think in a case like that, it's very important because, in my opinion, if you have normal vents and an oxygen transfer impairment present, then that's a case that it's more likely due to coal mine dust exposure, because if the impairment is due to smoking, then you're normally going to have an obstructive impairment before you'll have a gas exchange impairment. So you'll have abnormal vents. So if you have normal vents and an oxygen transfer impairment, then that indicates to me that something other than smoking, in this case, if the other factor that you have is coal mine dust exposure, then likely the coal mine dust exposure is a significant contributing factor. Am I over time?
Yes.
Okay. That's all right.
We're going to skip questions, but Attorney Staten will be available to answer any questions outside the conference hall. Thank you so much.